to chair the next session, I invite Dr. Santosh Sharma, sir.
Good evening. We come to the last session. So, we're continuing it's diabetes and heart. We are Dr. Arjit Kumar Ghosh from Nagpur. Is he over here? Yeah. Yes, sir. Please proceed.
Good evening. At the onset, I should thank the organizers for inviting me to Cardiodiabicon to give a talk on diabetes and heart. I would confess that my talk would be a very basic talk, would be an assimilation of all the learning which we have done over a period of time. It would be getting facts which we have learned, and in this mixed audience where we had the team of endocrinologists and the other specialists, nephrologists and the other specialists, it is just a assimilation of those talks. Just I wanted to start that why this heart has become important in diabetes is because there is a 2 to 4 times higher risk of cardiovascular disease in non-diabetics. Then when you have diabetes, the heart of cardiovascular disease increases. The disease is very rampant in the society, and you would realize that about 11.1% of the global adult population, which is the main workforce, are diabetic, and about 6.7 million deaths occur throughout. And out of this death, the major cause is because of the cardiovascular causes, and diabetics results in patients having 2 to 4-fold risk of cardiovascular diseases and an heart failure risk of 2 to 5-fold. Patients presenting with cardiac diseases have many times are unrecognized diabetes which have gone ignored, and these things are associated with other metabolic diseases and other diseases which can increase the risk factor. Just to summarize it, that cardiovascular death risk in diabetes is about 2 to 4 times higher. Type 2 diabetes and a prior MI, they are almost equivalent of an CAD risk. The diabetic prevalence in our country is about 77 million and is continuously rising. And heart attack, stroke in type 2 diabetes, there is twice likelihood in diabetic patients. I will just summarize what all the complications or the link that diabetes had with the heart in 3 simple disease manifestations. One is coronary artery disease, heart failure and arrhythmia. The coronary artery disease can be for the full spectrum. Then we have heart failure with preserved and reduced ejection fraction. Then there is an arrhythmic risk which is related to atrial fibrillation and sudden cardiac death and various arrhythmias. This pathophysiology, which slide we would have gone many times in this conference, it shows how diabetes affects the various systems and how does it cause the various problems. Just from the cardiac impact point of view, insulin resistance results in myocardial lipid accumulation, advanced glycation products results in myocardial stiffness, there is microvascular dysfunction because resulting in diabetic cardiomyopathy, chronic inflammation over a period of time results in atherosclerosis, and autonomic neuropathy is one of the finding facts in arrhythmia risk seen in patients. One important thing is autonomic nervous system dysregulation has been a hidden cardiovascular disease contributor. We are not focusing much because we do not have much data on this. This is an area where intensive research is required. Dysregulated autonomic nervous system increases the sympathetic affectivity, and this indirectly increases inflammatory markers and arterial stiffness, LVH and diastolic dysfunction. There is modulation in heart rate, ventricular volume and vascular resistance. Autonomic neuropathy affects the regulation of the heart rate and vascular tone, resting tachycardia and reduced heart rate variability. Patients may develop orthostatic hypotension and exercise intolerance. Cardiac autonomic dysfunction is one of the major reasons of arrhythmia and sudden cardiac death seen in these patients. Why diabetes increases cardiovascular risk is known from the various pathophysiology. Point to note is diabetic develops in heart disease at a younger age. 30 to 50% of type 2 diabetes have cardiovascular disease, and it is a risk equivalent to prior myocardial infarction. What is special about the diabetic atherosclerosis which we see in cardiology? It is an early and diffuse rapidly progressive atherosclerosis. It is multivessel disease. Plaques are vulnerable and prone to rupture. There is an endothelial dysfunction which reduces the nitric oxide availability and promotes vascular stiffness. Inflammation and lipid abnormalities accelerate plaque formation. Similarly, coronary artery disease in diabetes is another different subset. Patients have atypical symptoms. They present with dyspnea, and we are not aware that the patient does not have classical angina. Silent myocardial ischemia is known to occur. It results in sudden death and unrecognized MI. ACRs are associated with worse outcomes. There is extensive diffuse and complex coronary lesions. Revascularization strategies are challenging, and early detection and aggressive risk factor control are critical in patients of CAD in diabetes. There are various risk stratification scores known as Score 2 diabetes and QRISK-3, which I will not go into detail, from which we can predict the cardiovascular risk seen in patients with diabetes. There is a term, diabetic cardiomyopathy. This is a term in evolution. It is diabetic cardiomyopathy refers to myocardial dysfunction in the absence of CAD or hypertension. There is metabolic disturbances leading to myocardial fibrosis and structural remodeling. Lipotoxicity and impaired glucose utilization reduces myocardial efficiency. It starts with diastolic dysfunction, but it progresses with systolic dysfunction, and heart failure subsequently develops. Important point to note is diabetic cardiomyopathy is still not yet a distinct identity because there is lack of specific histology to define the condition. There are no biomarkers available, and clinical manifestation to allow definitive diagnosis or targeted treatment does not exist as on date. What about diabetes and heart failure? Diabetes increases the risk 2 to 5 times. There is poor prognosis. Diabetes and heart failure patients, the mechanism is that glucotoxicity, lipotoxicity, vascular endothelial dysfunction, and various microcirculatory abnormalities. There are underlying etiology associated with heart failure. To detect or to risk stratify heart failure, there is something known as WATCH-DM score, which has got various factors, which I will again not go into the detail. 1 unit increase in the score corresponds to a 24% increase in 5-year risk of developing heart failure. So such scores can predict in the early stage who are the candidates likely to develop heart failure. The management of heart failure is to screen all patients with heart failure for diabetes. Whenever you have heart failure patient, they should treat for diabetes. Regular assessment for symptoms and signs of heart failure, ECG and BNP. There is a role of echocardiography in which you can detect early diastolic dysfunction by global longitudinal strain. There is a role of MRI to detect myocardial dysfunction and myocardial fibrosis. The management of heart failure in diabetes is for people, as for the people of without diabetes, the 4 pillars of treatment. What is important is lifestyle modification should be stressed. Heart failure with preserved ejection fraction requires SGLT2 inhibitors and symptom management with diuretics. Now important is diabetes with atrial fibrillation. 40% higher risk of atrial fibrillation is present in patients with diabetes. Patients with coexistent atrial fibrillation and diabetes have poorer cardiovascular outcomes. Risk of stroke in atrial fibrillation is approximately 2% in the absence of other risk factors. Asymptomatic patients with diabetes should be screened for atrial fibrillation. This is an important carry-on point that patients with diabetes, we should look for atrial fibrillation. Diabetes and sudden cardiac death, again, they have an increased incidence of sudden cardiac death. The cause is related to ischemic heart disease, cardiomyopathy, and age. Evaluation for structural heart disease and arrhythmia is important. There is a link between hypoglycemia and sudden cardiac death. Type 2 patients having hypoglycemia, patients particularly at night, are associated with increased abnormalities of bradycardia, atrial ectopics, and ventricular premature beats. There are various specific glucose-lowering therapies which benefit CVD, which has been discussed all throughout the conference. I will not go into much of those details. Basically, SGLT2 inhibitors improves cardiovascular outcomes in people irrespective of diabetes. Similarly, GLP-1 receptor antagonists improve cardiovascular outcomes in diabetes across various randomized controlled trials. There are various guideline recommendations, and there are drugs. There is a benefit of metformin, pioglitazone in modifying cardiovascular disease risk, although this is less clear-cut. Pioglitazone should not be used in patients with heart failure. There are a series of next-generation cardiometabolic drugs which we discussed about. They are dual and triple incretins. Then there are various landmark trials which have proven that these therapies have shown a better cardiovascular outcome. The aim is to have a glucose-centric therapy to cardiovascular risk therapy. This is the hallmark which has been developed over a period of time. For heart failure, we have SGLT2 inhibitors. For atherosclerotic disease, we have GLP-1 receptor antagonists which reduce the MACE. Then HFpEF, we have SGLT inhibitors as the first disease-modifying drug. Obesity, cardiovascular ring, we have got semaglutide, and CKM continuum, which we heard is the finerenone, which is evolving. Type 1 diabetes and cardiovascular diseases, we do not have much data on this, and no much data has been received on this. There is emerging research area on diabetic cardiomyopathy, autonomic nervous system role, AI in diabetes, retinal imaging for cardiovascular risk. Lifestyle cardiometabolic drugs combining healthy lifestyle with cardiometabolic therapy reduces major cardiovascular events. There are future direction of research which is on. Various talks we have heard on precision medicine, molecular mechanism, novel therapies, digital health and remote monitoring to improve disease management. There is continued collaboration between specialty research which is on. In conclusion and clinical implication of my talk, diabetes increases risk of multiple cardiovascular condition, coronary artery disease and heart failure. Mechanism involves metabolic, inflammatory and vascular pathways. Early detection and aggressive management of risk factors are essential to reduce cardiovascular complication. Modern anti-diabetic medication now offer cardiovascular benefits. Comprehensive and multidisciplinary approach is critical to improve outcomes in patients with diabetes and heart disease. Personalized and holistic approach tailored to patients, which is evidence-based and patient-centered, is important. The takeaways are lifestyle and risk factor modification by the ABCDE approach. In addition, screening for silent ischemia, multifactorial control, refer to cardiologist if the ejection fraction is low, role of coronary calcium score. Thank you.
Thank you, sir. Any questions from the audience? Okay, so I have one query. We all know the UK PDS trial has shown that there is no macrovascular benefits with a strict blood sugar control. So what is the ideal time when the patient should be intervened to prevent all the cardiovascular risk factors and the cardiovascular morbidity and mortality in a diabetic patient?
A patient with diabetic, when we should intervene for cardiovascular side. Basically, a patient with diabetes, we have to assess the risk score. Based on the risk pattern where he falls on the risk score, we have got the basic investigation from ECG, echo, calcium score and stress test. So on this format, based on the risk score, you can find out early where the patient is having coronary artery. If a patient is symptomatic, it is out of question. Asymptomatic patient, based on the risk score, the management is decided. That's why I showed that risk scores, if he falls into any of the high or moderately high risk, the therapy is started. Otherwise, we have drugs nowadays, which are common drugs in both fields, which have shown to have cardiovascular outcome benefits, even if the patient does not have diabetes.
Thank you, sir.